Hello everyone, it's Dr. Locklear and I'm coming to you today with Exemplar 18.D, Peripheral Neuropathy. And this is a condition that is very debilitating and painful and can cause a lot of problems in the lower extremities. We're going to describe the pathophysiology of how peripheral neuropathy develops. We're going to look at the causes of peripheral neuropathy. We're going to look at the risk factors and how can we prevent it. There's some things that you can do. Identify the clinical manifestations. So what do you see when you're assessing your patients? And what kind of complaints does the patient have? Summarize the diagnostic test, any therapies that the team will use, and how do we collaborate care for this patient. We're going to differentiate considerations for care of patients with peripheral neuropathy across the lifespan, and we're going to apply the nursing process in providing culturally competent care. And, what do we do when we assess, and what are the things we implement when we work with these patients? So let's get started. Peripheral neuropathy results when trauma or a disease process interferes with innervation of peripheral nerves. The overall effectiveness of blood vessels decreases, and superficial blood vessels constrict to divert blood to larger vessels. So when you have this constriction, you have a decrease of blood, which leads to a decrease of oxygen to the tissues, and that's going to cause a lot of pain in those areas and a lot of tissue damage because of the decreased oxygen. With the constriction of peripheral blood flow vessels, peripheral nerve endings in the constricted area experience decreased blood flow, decreased oxygen, and neuropathy develops. Although most peripheral neuropathies progress slowly over time, the symptoms, including pain and muscle weakness, can significantly affect the quality of life, and it is a painful disorder. The patho and the etiology. The peripheral nervous system links the central nervous system with the rest of the body. The peripheral nervous system is responsible for receiving and transmitting information from and about the external environment. It consists of nerves, ganglia, which are groups of nerve cells, and sensory receptors located outside or peripheral to the brain and spinal cord. The peripheral nervous system is divided into a sensory afferent division and a motor efferent division. Most nerves of the PNS contain fibers for both divisions, and all nerves are classified regionally as either spinal nerves or cranial nerves. So what happens what's the process? The main components of the peripheral nervous system are the axon and the myelin. Peripheral neuropathy can be classified according to the predominant pathology: axonal degeneration or segmental demyelination. And that's just a breakdown of the protective barriers around those nerve endings. Damage to peripheral nerves can interrupt communication between the brain and the body, affecting normal muscle function and sensory perception and causing pain. A lot of patients say it feels like their legs are crawling and tingling at night, and they have restless leg syndrome. The peripheral neuropathies, also called somatic neuropathies, include polyneuropathies and mononeuropathies. Polyneuropathies, the most common types of neuropathy. These are associated with diabetes. They're bilateral sensory disorders, bilateral meaning on both legs. The manifestations appear first in the toes and feet and progress upward. The fingers and hands also may be involved, but usually only in later stages of diabetes. The manifestations of polyneuropathies depend on the nerve fibers involved, and poly meaning many. Mononeuropathies are isolated peripheral neuropathies that affect a single nerve. Injury or trauma is the most common cause, although repetitive motions such as those resulting in carpal tunnel syndrome also can cause mononeuropathies as well. So what is the cause? Neuropathies are classified according to cause: acquired, heredity, or idiopathic. Acquired neuropathies include those caused by disease or illness, nutritional deficits, infection, trauma, and toxins. Hereditary or inherited neuropathies include Charcot-Marie Tooth disease, which is a disease of the foot and the lower leg, and it affects the muscles. Idiopathic neuropathies are from an unknown cause. The etiology of polyneuropathy is varied. It often is caused by systemic diseases, exposure to toxins, and poor nutrition, in particular vitamin B deficiency. Damage from disease processes such as metabolic and endocrine, such as diabetes, disorders affects the body's ability to process waste products and utilize nutrients. Approximately 70% of individuals with diabetes develop some type of neuropathy. Conditions that decrease oxygen supply may cause a thickening of the walls of the blood vessel that supply nerves, resulting in reduced blood flow. Autoimmune disorders and infections also can cause peripheral neuropathy. Viruses and bacteria can attack nerve tissues or cause the body to attack nerve tissues, resulting in the destruction of nerve axons or the myelin sheath. And so when that axon and myelin sheath is destroyed, then those nerve endings are exposed and it causes irritability and they don't function correctly. One of the most serious polyneuropathies is Guillain-Barré syndrome, or GBS. It's a demyelinating disorder of the peripheral nervous system that results from both the humoral cell-mediated immunologic response. GBS is one of the most common peripheral nervous system disorders. The cause is unknown, but certain factors such as respiratory or GI viral or bacterial infections 1 to 3 weeks before the onset of the manifestations is possible. Surgery, viral immunizations, and other viral illnesses are some of the causes. GBS is characterized by progressive ascending flaccid paralysis accompanied by paresthesias, subjective feelings of a change in sensations such as numbness or tingling. About 20% of the patients have respiratory involvement and end up on a ventilator because it debilitates their muscles to the point that you're not able to breathe effectively. Sensory neuropathies with manifestations of numbness, tingling, and pain in the lower extremities affect about 30% of patients with AIDS. A GBS type of inflammatory demyelinating polyneuropathy also can occur, resulting in progressive weakness and paralysis. In addition, untreated Lyme disease can cause extensive peripheral nerve damage as well. Other diseases processes that result in peripheral neuropathy are alcoholic neuropathy is damage to the nerves that results from long-term excessive use of alcohol. Malnutrition. Malnutrition is a serious complication of chronic alcoholism. Thiamine, which is B1 deficiency that may be associated with chronic alcoholism, is characterized by progressive cognitive deterioration, confabulation, myopathy, and peripheral neuropathy. Inflammation, cancer, and toxins, including some types of chemotherapy, other medications, and environmental chemicals such as lead, can damage nerve tissue and fibers, resulting in peripheral neuropathy itself. Inflammation and swelling in tendon sheaths can lead to peripheral neuropathy also. The carpal tunnel is a canal through which flexor tendons and the median nerve pass from the wrist to the hand. Carpal tunnel syndrome develops from narrowing of the tunnel and compression of the median nerve as a result of inflammation and swelling of the synovial lining of the tendon sheaths. Some of the risk factors, these include diabetes, alcohol use, vitamin deficiencies, particularly B vitamins, immune system suppression, autoimmune diseases, exposure to toxins, kidney, liver, or thyroid disorders. Age also appears to have a role in the risk for peripheral neuropathy. Studies show that the incidence of PN increases significantly in older adults because we have other comorbidities such as plaque buildup in our vessels, hardening of the arteries, which is atherosclerosis, heart conditions, and all of these can affect the circulation. Height has been identified as a risk factor for the development of PN, independent of gender or presence of diabetes. A man that's taller than 5'6" and a woman taller than 5'3" are at risk. Nurses should be aware of the risk factor and use it to identify individuals who are at higher risk for PN, especially if patients also have other risk factors such as diabetes or excessive alcohol use. Controlling medical conditions that increase the risk for peripheral neuropathy is one of the best prevention methods. Controlling the risk factors, those modifiable risk factors. A diet healthy in vegetables, fruits, and whole grains can help improve nerve health. Intake of vitamin B12 can be helpful as well. Avoiding triggers that contribute to nerve damage, such as repetitive motions, smoking, excessive alcohol consumption, toxic chemicals, cramped positions, will also help prevent this disease. Manifestations: the patient with polyneuropathy commonly has distal paresthesias, pain described as aching, burning, or shooting, and feelings of cold feet. Other manifestations may include impaired sensations of pain, temperature, light touch, two-point discrimination, and vibration. With GBS, there is frequently a stocking glove pattern, feeling as though stockings and gloves are being worn when they are not, with pain in the hands, feet, and legs. Weakness in the arms or legs is often caused by damage to motor nerves. Patients may report difficulty walking or running, stumbling, dropping things, and tiring easily. A general feeling of lack of coordination or clumsiness may be reported, and the patient may compensate by changing the walking pattern to maintain balance. And you have a safety alert here. It says symptoms of numbness or weakness in the legs and feet increase the patient's risk for falls, which in turn increases the risk for injury and infection. Teach patients with PN to be aware of obstacles that may cause tripping. Also teach patients how to call for help if they fall and cannot move. This is the Charcot-Marie tooth disease that the chapter referred to. It's most commonly inherited peripheral neuropathy, slowly progressive degeneration of the muscle in the foot, lower hand, and the forearm. Symptoms start between adolescents and young adults. And I don't know why it's called Charcot-Marie tooth disease. I need to do further investigation on that. Collaboration. The primary goal of treatment is to correct or manage the underlying cause so that symptoms are controlled and further nerve damage is minimized. Prevention is always the key. Diagnostic tests: electromyography to check the muscle function, a CBC to check for elevated white count, signs of infection, signs of inflammation, thyroid function, make sure your thyroid's functioning effectively, B12 and thiamine, metabolic panels, urine screenings, and nerve biopsies. Lyme disease and HIV tests also may be indicated. Surgery. Surgical intervention may be appropriate when peripheral neuropathies are caused by compression, as in the case of nerve tumors, carpal tunnel syndrome, and peripheral nerve injuries. Patients with CMT disease may also be good candidates for surgery, especially for foot reconstruction to straighten clogged toes, flatten high arches, and stabilize ankles. Neuropathies caused by medical pathology such as diabetes cannot be treated with surgery. Safety alert. In an individual with PN has an injury that gets infected and develops gangrene, surgery may be required to amputate the infected extremity. Therefore, nurses should encourage patients to regularly check their extremities for injury and infection to avoid progression to gangrene and amputation. And with the diabetes patient, and you've got peripheral neuropathy, you can't feel. And so you may have an infected toe or toes and you can't feel it. And so you need to do close observation. Pharmacological therapies: pain relievers, over-the-counter acetaminophen, ibuprofen help with the inflammation. Anti-seizure medications, and some of these are listed on page 1437. Tegretol, which is carbamazepine, Neurontin, which is gabapentin, Lyrica is pregabalin, and Topamax is topiramate. And Topamax and Tegretol are both long, old standing drugs. The tricyclic antidepressants, Elavil and Pamelor, and then your SNRIs, which are your Cymbaltas. A lidocaine patch, and that's a patch that's put on, and you see a picture here. It helps relieve the pain. Non-pharmacological therapy, changes in daily life, adherence to therapeutic regimen, healthy, well-balanced diet, more fruits and vegetables, B12 supplements or foods high in B vitamins, maintain optimal weight to reduce blood pressure, avoid smoking so your vessels aren't constantly constricted, limit alcohol intake, regular exercise, and daily foot care. You need to take care of those feet. Complementary health, acupuncture, biofeedback, massage, and your TENS, and it gives you a little overview of what a TENS is on page 1438. Patients with Guillain-Barré, usually for children, is the leading cause of acute paralysis, and it's rare since the eradication of polio. Symptoms for infants, hypotonia, they have poor muscle function, respiratory distress, of course, difficulty feeding, children less than 6, refusal to walk, pain in legs, and older children are similar to adults. Patients with Guillain-Barré, pregnant, if you're pregnant, diagnosis often is complicated, more severe in pregnant women because you're pregnant, you're already in distress as it is, and then of course in the older adults, and that's where you usually see that with patients with the Charcot-Marie-Tooth syndrome. Commonly appears in childhood and adolescence, and then it carries on over into adulthood. Problems with dexterity and hand strength and ADLs. It says CMT is a genetic disorder that can be evident at birth, but it more commonly appears in childhood, adolescence, or early adulthood. Although the CMT is a genetic disorder, many forms of the disease are autosomal recessive, so patients do not realize they are carriers of the disease until their child is diagnosed. For this reason, and in combination with the fact that symptoms are very mild early in the course of the disease, patients may not be diagnosed with CMT until years after the symptoms begin. Early in the course of the disease, symptoms may manifest as clumsiness due to foot drop and muscle weakness in the feet, ankle, and legs. As the patient ages, symptoms become more pronounced because of muscle wasting and lack of sensation in the extremities. This may lead to problems in dexterity and hand strength, making ADLs more difficult in older adults. The consistent alterations in posture to compensate for muscle problems can cause muscle and joint pain. Most older adults with CMT require walking aids such as a cane or a walker. Diabetic peripheral neuropathy is rarely seen in children. Children and adolescents who are at higher risk for developing peripheral neuropathy include patients with poor glycemic control and longer duration of diabetes. Children with diabetes should be screened annually for peripheral neuropathy. Like other patients with diabetic peripheral neuropathy, children and adolescents should be taught how to properly control their blood sugar, monitor their diet, and adequate foot care. The nursing process requires significant collaboration with the patient and essential to establish effective communication with the patient. We got to know what's going on with them. A health assessment to determine problems with peripheral nervous system may be conducted during a health screening, may focus on a chief complaint such as tingling, or may be a part of total health assessment. Analyze onset, characteristics, course, severity, precipitating and relieving factors, and any associated symptoms, noting the time and the circumstances. So what do we see when we observe? Observation of a patient with peripheral neuropathy includes watching as the patient walks to notice foot drop, shuffling steps, or lack of coordinated movement that may indicate a feeling a lack of feeling in the feet. The patient may also have trouble with coordination if peripheral neuropathy affects the hands. Questions about the patient's present health status include information about numbness, tingling sensations, tremors, problems with coordination or balance, and loss of movement in any part of the body. Carefully assess older adults for impaired imbalance and fall risk. Ask the patient about difficulty with other senses, including detecting odors. In addition, assess for mood and anxiety, changes in sleep patterns, and ability to perform self-care and ADLs, sexual activity and weight. Inquire about the use of medicines, over-the-counter products, herbal supplements, history of seizures, fainting, dizziness, headaches, infection, and trauma, any tumors, any surgery of the brain and spinal cord. Discuss illnesses that may cause neurologic manifestations, including cardiac disease, strokes, pernicious anemia, and sinus infections, liver disease, and or renal failure. Also ask the patient about family history of neurologic health problems, diabetes, hypertension, seizure, or mental problems. Question the patient about occupational hazards such as exposure to toxic chemicals and materials, the amount of time spent performing repetitive motions such as somebody that does data entry on a computer, information about their diet and tobacco and alcohol use and drugs and use of safety and protective equipment as well. So a lot of questions you have to ask during the interview. The physical assessment, it should include testing peripheral pulses based on the affected extremities. A gait assessment should be performed to test the patient for gait, balance, and risk for falls. The gait assessment should include walking for a minimum of 10 feet. A vibration test can also be used to test sensation in each affected joint. A pressure test can be done by touching random points with a monofilament to detect sensation. Deep tendon reflexes should be tested. A physical exam should also include the cranial nerve assessment. So you can do a very detailed assessment of functioning of the lower extremities. Your nursing diagnoses using NANDA, risk for injury, ineffective peripheral tissue perfusion, pain, chronic, and anxiety. And that's not all of them. Goals: remain free from injury, report effective pain management, and verbalize feelings, concerns related to sensory loss. And you could have put other things in there like adhering to a proper diet, losing weight, exercising. There's many things you could put. Prevent injury. Ensure patient safety. Patients with compromised feeling in the extremities may be unaware that they have sustained an injury. Teaching topics, depending on the type of peripheral neuropathy and the extent of nerve damage, may include the following. Foot care, as the patient may not feel injuries to the feet, and there's teaching on foot care in the diabetes chapter. Exercise, walking, active range of motion, lifting your feet up and down in your legs. Smoking cessation. There's a table in the oxygenation module 15-2. Avoidance of toxic chemicals. Nutrition, stressing importance and identifying the sources of B12 vitamins. Avoidance of repetitive motion and prolonged pressure. Massage to improve circulation, stimulate nerves, and reduce pain. Promote comfort. Pain experienced with peripheral neuropathy varies. Pain and tenderness in muscles can be severe. Interventions must be individualized to patient needs. The intense pain combined with outer sensation leads to anxiety. Nursing interventions can make a difference in breaking the cycle of increasing pain that leads to increased anxiety, which causes more pain. Listen to the description of the pain. Determine the presence of the triggers or pattern. Acknowledge the patient's perception of pain is a basis for treatment. Listening establishes trust. Use a pain scale for determining the extent of the pain and consistent measures to evaluate the degree of pain. Provide analgesics. Administer them on a regular schedule. Anticipating, imagining pain before it becomes severe. So when the patient first complains of pain, if they can have pain medicine, go ahead and give it to them. For patients with Guillain-Barré, monitor for side effects of analgesics, particularly respiratory depression, assess respirations and lungs, because you're listening for signs and symptoms of infection. Perform routine pulmonary care measures and monitor for aspiration. Turn and reposition that patient. Get them up out of bed. Frequent respiratory monitoring. The following complementary health approaches may be used: application of heat and cold, guided imagery, and relaxation techniques. And then your evaluation: patient experiences pain control to allow for rest and comfort. Patient lists strategies to reduce risk of injury, promote safety. Patient describes treatment plan to reduce further deterioration. And worsening symptoms should be addressed.